I think I should start with a bit of a disclaimer. I feel like I'm the person in the room who probably knows the least about genetics and genomics. I don't even know how to say it. But I think the fundamentals of what I'm going to talk about today could have important implications for some of your work. So I think what I'd like you to do, if possible, is to think about your own work, what you're doing day to day, and think about how this might apply, because I think it could be important. So I'm going to introduce you to the idea of individualized cost-effectiveness analysis, and then I'm going to introduce you to the idea of risk-based screening and how we'll combine these ideas, and then I'll present some of the practical and ethical challenges associated with doing this, and then I'm going to suggest why I think that actually it is practical and ethical. So individualised cost-effectiveness analysis. It's worth noting that this is my interpretation of individualised cost-effectiveness analysis. This isn't something, if you go into Google Scholar and type it in, you're not going to find anything that well developed in terms of what individualised cost-effectiveness analysis means. It's a term that has been used but hasn't seen much research. I interpret it as the estimation of expected costs and outcomes and their combination at the individual level. So this isn't how we do things in health economics, and we measure everything at the population or sample level, and we apply means, mean costs, mean outcomes, and this, for NICE in England, makes things quite easy ethically. It rules out discrimination, things like that. So when we start to think about it, it starts to raise problems. But actually, in terms of methodology, I don't think we really need any big new ideas. I actually see it as an extension of something that's already been written about a decade ago. Mad that 2003 was over a decade ago. Doug Coyle and colleagues presented something called stratified cost-effectiveness analysis. So all this is measuring net benefit, cost-effectiveness essentially, at subgroup level. So you chop your population up into subgroups, estimate costs and outcomes for that subgroup, and see whether it's cost-effective. And then how this would influence practice is that your total net benefit of the total programme of providing the intervention is just the sum of net benefits for all subgroups in which the intervention is cost effective. So you kind of stop doing it for subgroups where it's not cost effective. So I see individualised cost effectiveness analysis as an extension of this, a kind of special case, because when we're doing individualised cost-effectiveness analysis, we're talking about one person. So our subgroup is just one person. So this can be summarised by these kind of 2 points. So your subgroups, the number of subgroups, potential subgroups, tends towards infinity. There's not really any limit to the number of potential subgroups you could have. And the size of these subgroups tends to 1. Now this is a big problem. So you can't measure costs and outcomes based on n equals 1. I mean, hopefully you all can kind of see why that would be a problem. Essentially, you can never know the counterfactual. You would never know what would happen if that person didn't receive treatment, if you do give them treatment. So it's impossible, right? You can't do individualised cost-effectiveness analysis. Well, what if these subgroups weren't actually completely separate and different? What if there was some kind of underlying universal factor which related them all to each other in such a way that you could estimate the costs and outcomes based on that underlying factor to individualised care? Enter risk-based screening. So we can now reliably estimate an individual's risk of disease onset. And how this works usually is you would define subgroups based on individual risk level. So you can have high, medium, low risk. But it's difficult, I would argue impossible, to define any kind of clinically meaningful subgroups, because any given difference in risk is the same wherever you are on the scale. And it's important to define, when you're defining subgroups, it's important that they are clinically meaningful. So studies are being, I say studies, I'm only aware of one observational study, which is what I'm working on, but I'm sure there's others. Studies are being funded to explore risk-based screening. In fact, Catherine Payne mentioned earlier a study. So these normally involve this stratification based on risk thresholds. So, for example, there may be high risk at which you do provide screening and low risk at which you don't. But on what basis do you define these thresholds? It could be acceptability, so you could go to patients, maybe the public, and say, what is a reasonable level of risk that you're willing to take? It could be on safety. You could say we're willing to accept this many missed disease cases. It could be affordability. You could say we've got a fixed pot of money. We can screen however many people, and we're going to screen the people that are most at risk. Or, being an economist, it goes without saying that when I was in the early meetings for one of the studies I work on, and they were talking about this, I naturally thought, why can't we do it based on cost effectiveness? So our thesis is that there's a direct link between individual risk of disease onset and the cost effectiveness of screening them for that disease. And we think that in most cases there will be a threshold level of risk for cost effective screening. So above that risk threshold, screening will be cost effective, and below it will not be cost effective. So we can use this threshold to individualise screening. This might be a screen, don't screen kind of scenario, or, and this is where I think it gets quite interesting, you can personalise screening recall periods when it's the type of screening that takes place more than once in a person's lifetime. And we believe that risk-based screening, as I'm going to talk about today, is compatible with the kind of prevailing ideas of distributive justice in healthcare and the kind of philosophy of health economics that's kind of presented by NICE, really. So what we do is we think about kind of a standard screening model here. This diagram here is kind of how most screening programs look at the basic level. So you have an individual, and they are either screened or not screened. And then whether they're screened or not, they either have a positive disease state or a negative disease state. And then people who are screened, there's the potential for false negatives and false positives. So essentially there's 6 possible outcomes. So we created this basic model, which we think is broadly generalisable, but yet it can of course be tweaked. And what we did is we established a number of assumptions for the sake of demonstrating how we think this relationship between risk and cost effectiveness could work. And these can all be relaxed. But essentially, we're assuming that the only outcome of interest really is a true positive outcome, and everything else is the same. But as I say, these can be relaxed. And what you end up with is these figures here. So essentially, these are just standard ISA and net benefit calculations that you would do in an economic evaluation, but they incorporate this R, which is the individual level of risk. So these hopefully don't look entirely alien to people. So we're incorporating individual risk into the cost effectiveness calculation. And we did this for some published studies. We took a study of diabetic retinopathy screening and a study of colorectal cancer screening, and we took the figures and plugged them into our model, and you get this relationship, which is what we were expecting. So along the x-axis, we've got individual risk here, ranging from no risk to a 5% risk of disease onset, and up the y-axis, we've got cost per true positive screen. So this is measure of cost effectiveness, and this could equally as easily be cost per quality. So you can see that individuals with low risk, if we consider an individual with say a 0.5% risk, 0.5% risk being screened for diabetic retinopathy, the cost per true positive screen would be about £4,000, whereas if they had a 2% risk, it would be about £1,000, which makes sense. The more people you're screening, the lower their risk, the fewer people are going to screen positive and benefit from treatment, and so it's less cost effective. This is kind of intuitive, and hopefully you can start to see from this how you might start to think about a threshold based on cost effectiveness. And so you can estimate net benefit. This is for the diabetic retinopathy example. So if you're willing to pay £500 per true positive screen, then the threshold would be about 5%, whereas if you were willing to pay just £200, it would be about 10%, in which case you'd screen everybody with a risk above 10%. I'll say where this gets really interesting is when you start to think about personalising screening recall periods. So diabetic retinopathy, at the minute, people with diabetes are screened once a year. for diabetic eye disease, for retinopathy. And there's a big literature now developing saying that actually this isn't a good use of resources. Most people could be screened every 2 years or even more. So what this figure shows, along the x-axis we've got optimal recall period, and on the y-axis we've got individual risk. So you can see that as an individual's risk falls, the lower an individual's risk, the less frequently we need to screen them, the longer we can leave it until we invite them back for a screening. So this has some practical challenges. It requires the creation of an accurate risk calculation engine, which requires lots of data and know-how. And so it's quite high upfront costs. It requires simple and regular estimation of individual risk. So you can't have doctors in practice spending ages calculating people's risk level. It requires, in the case of diabetic retinopathy, for example, it requires the capacity for variable recall. So at the minute, letters are just sent out once a year, and it's very simple. But under our program, it would require something more complex. And it needs to be acceptable with patients and physicians. This is particularly important when you consider that where a screening program already exists, if people are being screened once a year, and some people are going to subsequently be screened once every 2 years, some people are going to lose out. There's going to be people who develop disease and are missed no matter what. Even though it's improving in the way we think about cost effectiveness, it's non-Pareto improvement, so somebody's going to lose out. So is it practical? Well, as I say, I work on a study which involves lots of work streams, but we're doing an RCT where people are randomised to either standard annual screening for diabetic retinopathy or to a variable program. And we're doing it, it's working in practice. And it doesn't really have any incremental administrative costs to run because our ICT system just generates a letter at the right time. And so we've not had to employ anybody extra to run it. The only cost really is the development of the risk calculation engine. So the ethical challenges, well, there's a few, but the two important ones that I see are non-discrimination and priority to the worse off. These are two things that we kind of think are important when we're doing economic evaluations. So if you assess cost effectiveness at the individual level, it raises the possibility for discriminatory outcomes. So the optimal risk-based screening program may exclude particular groups. And also there's issues, if people don't share data, then the model's not going to work as well, and it could affect those people more. It could vary by region because you'd want your risk calculation engine to work at the local level. And also priority to the worse off. It's possible that the risk-based screening program could favour people who are already healthier, and generally we have a bit of a problem with that. We want to prioritise the worse off in terms of their need. But actually I think we can do this. I think we can kind of take the easy option and we can implement this. So I think there's two important things and then a third optional extra that we could do to make this ethically feasible. So we can apply average costs and benefits from the population. So this means that only probabilities of the different outcomes are differing across individuals. So in this net benefit calculation, you can see that the net benefit for I builds in kind of population average outcomes and costs, and it's only the risk which is different. So this means that we're only discriminating based on risk, and I don't think this counts as discrimination in the way we normally think about it. Individual risk is kind of, I've called it here, suprapersonal characteristic. It's not a personal characteristic in the way we normally think about it. I don't think it should hold the same moral weight as, for example, race or sex. And individual risk of disease onset is not dependent on resource allocation in the same way as costs and outcomes. So I don't think it should bear the same moral responsibility. I don't think public providers, should bear the same moral responsibility in its regard. So I don't think non-discrimination is an issue. And we can personalise screening, for example, screening intervals, only on the basis of individual risk. So the way I see screening is it's an assessment of need. You don't really get health benefits from screening itself. Capacity to benefit, which is the way we tend to think about need, is kind of instrumental. So this is important because if you individualise screening based on risk, it maintains proportionality in the distribution of expected healthcare. So everybody's screened at the point they get to a certain risk level, at which point everyone would have the same probability of benefiting from treatment. So actually, by better defining the relevant aspects on which we want to have equitable healthcare, it better defines need, it increases horizontal and vertical equity. And thirdly, for kind of face morality, I don't know if that's a term, but for kind of face morality, we can exclude contentious factors such as race from the risk engine and actually build in kind of clinical indicators which people don't have so many concerns about. So the take-home messages from me are that we think there's a fundamental relationship between individual risk and the cost-effectiveness of screening. And I think that's kind of a given. It's implicitly recognised in existing screening programs. And we think it's practical to estimate individual risk in clinical practice because we're doing it. We're already doing it, and it's going really well. And we think you can use individualised cost-effectiveness analysis to personalise screening without discrimination, at least not in the way we normally think about it.